It is now my great privilege to introduce the Grand Round speaker for today, Dr. Shawn Rangel. It would take the entire hour to go through his CV, but just to give you a brief summary of his numerous accomplishments. He received his medical education up the road at UCSF and subsequently came right here to Stanford, where he completed his internship and residency in general surgery, and also earned a master's in clinical epidemiology. He then completed his pediatric surgery fellowship at Cincinnati Children's Hospital before becoming faculty at Boston Children's Hospital. He is a professor of surgery at Harvard Medical School and the Weitzman Family Chair for the Advancement of Quality and Safety at Boston Children's Hospital. He also holds numerous other leadership positions, including the Director of Quality Improvement and Patient Safety for the Department of Surgery, the Senior Surgical Advisor for Quality and Patient Safety, and the Director of the Health Services Research Fellowship. He is recognized as a national and international leader for quality and safety in pediatric surgical care, and is also considered to be an expert in antimicrobial stewardship in the perioperative space. He led not one, but two national collaboratives that resulted in major paradigm shifts in the data that is captured and reported by the Pediatric National Surgical Quality Improvement Program, or NSQIP for short, one of which was targeted antimicrobial stewardship measures for surgical prophylaxis utilization. And as a PEDS ID person myself, I will also note that he's contributed to stewardship in other ways through some PCORI-funded research related to oral versus parenteral antibiotic therapy for osteomyelitis, appendicitis, and pneumonia. So truly, he is one of our surgeon champions in the ASP realm. So it should come as no surprise that he was invited on behalf of the PEDS ID division and specifically the ASP team. And so we are thrilled to have you here. Welcome back to Stanford, and we look forward to your talk.
Great, thank you, Lauren. So I have my microphone on. Can people hear me okay? All right, great. So thanks again. It really is incredible to be invited back to the farm and talk about a topic that I'm really passionate about. And you know, I have to say it's a little surreal to be back here. I was an intern here at Lucille Packard 25 years ago. And to kind of date me a little bit, that's when Eric Skarsgård was the chief, and Larry Moss was here, Baird Smith. And that was also the time that I decided to become a pediatric surgeon, right? So that was also the time where I wrote my first chapter, PEDS ID chapter for Charles Prober. So that's probably a more important milestone, right, than becoming a pediatric surgeon. But it really is incredible. The first disclosure I have is I really hate this picture of me. I look too serious and constipated. And it reminds me that I need to like reshoot that for the next Grand Rounds or so. But I have a couple of disclosures that I want to hit on as well before I get started. The first is that I am a paid site reviewer for the ACS. I do verification visits. You guys have one in a couple of months, right, for verification. And so I know no one's going to throw tomatoes at me because I know where to go and complain about that. No one gets rich doing this, and I certainly don't either. I don't think there are any fiscal issues with that. The more important disclosure is really acknowledgement of some of the great work that has come out of our fellows. We have a lot of outstanding fellows at the ACS and at Boston Children's who have done a lot of great research, and a lot of the data I'm going to be sharing with you. And I see Gillian over there, and so she knows all about a lot of these people here. They've done a lot of the great work, and I really want to acknowledge them. So never underestimate what you can do as a trainee to move the needle. And so what I'm going to touch on today is a topic, again, I'm very passionate about, and it's very well depicted in this picture. And clearly this is the artistic rendition of a bunch of surgeons prescribing antibiotics at a typical children's hospital. And what you're going to see over the course of my talk is the data is crazy, right? How much variation is out there. So it really is the Wild West. And what I'm going to touch on today is really the story or the tale of two programs from the American College of Surgeons. One is the National Surgical Quality Improvement Program, which is our measurement program for quality and safety, and then the verification program, which of course verifies centers based on their infrastructure and dedication to continuous quality improvement and that sort of thing. And so what have these programs done to try to tame the Wild West a bit? And although I'm going to be talking in the context of surgical diseases and conditions, the concept and the approach really is applicable to any conditions or diseases where there's a ton of antibiotic utilization, particularly where there's a lot of variation as well. And so kind of think about it in that context, and hopefully I'll inspire you to think of it differently and how you might measure some of your medical conditions as well to improve stewardship. So why care about this stuff? This is easy in this audience, right? Because you guys are all peds ID mostly, and pediatricians, we understand this stuff and we embrace it. And we're all familiar with these news articles, super bugs, and all the issues that come out, right? This has, become a little bit tiresome in the news. But what I think a lot of folks don't understand, particularly the lay folks, is really the public health implications, right? In that there are now models that suggest by 2050, deaths due to resistant organisms will eclipse cancer in terms of the #1 killer. Now, there might be some issues with that modeling, but I think, we're biased toward believing the modeling. It's definitely going to be somewhere in that nature. And so there is really some significant public health issues that we need to contend with. The other issue is it costs a lot of money to treat these bugs, right? And this right now, this is data from the CDC, and it's probably a little outdated. I'd probably say that it's probably about $10 billion a year now that we estimate the excess cost of treating these organisms. And so there's definitely kind of, important fiscal implications as well. And then the last background slide I'll show you is just some data. Again, it's a little dated, came out of Lancet Infectious Disease about 10 years ago, but still very relevant. And that is that if you look at the rate of resistant infections associated with common SSIs for common surgical diseases, right? So these are increasing over time. And there's very little data to look at this with peds, but the little data that there is suggests that we're seeing the same trends. The reason this is terrifying to me, and probably to you guys as well, is that the pipeline to create new drugs, new antimicrobials, is dry, right? If you look at the past 2 or 3 decades, the R&D budgets of major pharmaceutical companies have tanked. Why is that? It's because there's no money in it for them, right? They make a lot more money making other medications. And so at some point in the next probably 5 to 10 years, there's going to be a real big crisis, right? Something's going to have to give, and it's probably going to be like a COVID moment, right? Where all of a sudden those pharmaceutical companies are going to be forced to really change on a dime. And that's going to be a very, very, very scary time. And we know in pediatrics, right, particularly, for medicine, we know for surgery, the overuse of antibiotics is pretty rampant. So kind of coming back to our tale of 2 programs here. So what is NSQIP, or what is the ACS doing to try to combat this? And the first thing I want to touch on is what we're doing in terms of measurement. And what are we learning, and then how do we implement this in terms of making things better? And so because this is a pediatrics audience, you're probably not too familiar with pediatric NSQIP. Because you're a verified center, you probably know a little bit more than non-verified centers. But NSQIP is surgery's premier adjusted comparative performance platform. So this is how most hospitals compare their surgical outcomes to other hospitals. Now, this has been around for about 30 years in the adult world. In kids, it's been around since about 2010. And the reason it's evolved to be so important and powerful is because it's not administrative data. It's real data, clinical data that's abstracted by real people with usually nursing backgrounds. Are the SCRs in the audience by any chance? Yeah, over Zoom. Okay. Yeah. And so they really make the program go around, right? So they use very rigorous processes to abstract data, including adverse events and also risk-adjusted comorbidities as well. And so it's really the premier way in a risk-adjusted fashion that you know how you're doing. And it really tackles everything that's non-cardiac. So it's different than the STS database. And kind of the key output of this is the semi-annual report that all hospitals, including Stanford, get. And this gives you an idea of the scope of this. This is just one of our semi-annual reports, the types of measures that are included in it. And one of the key ones for this group is the surgical site infection rates, right? Because these are really rigorous data, right? So when you compare, it's not only comparing against very standardized definitions across hospitals, but the 30-day follow-up is not just, did it happen in clinic? Did it happen in the hospital? They call the parents. They follow up with the pediatricians. It's really rigorous to make sure nothing falls through the cracks. And this gives you an idea of what a report looks like. And this shows us our trends over time. This is a little bit of our dirty laundry in Boston. And you can see how there are different outcomes here. These are the different reporting periods. These odds ratios are risk adjusted versus the NSQIP, basically the whole universe. And you can see in this reporting period, we had a problem with our pneumonias. And it turned out when we did a deep dive with our infection control people, we had a spike in VAPs, for reasons we still don't understand. But the power of the NSQIP data is it does give you a comparative flag, right? So if you have a problem somewhere, it will tell you compared to the national norm, so you can do a deep dive and try to figure out what's going on. Well, the program changed dramatically about 10 years ago, and that was because of verification. So how many people know what children's surgery verification is, even though you're a verified center? No one? Yeah. So the verification program, you guys are a verified center, by the way, you're becoming re-verified in 2 months, is you can think about it as like a NICU designation, right? And so there are standards for personnel, infrastructure, dedication to continuous quality improvement, and these types of things. So the ACS has now started to verify centers in 2016, big centers like Lucille Packard, as 1, 2, or 3 level designation. And so if you're a level 1 designated center, that's a big deal. There are about 60 of them now in the United States. And you have to jump through a lot of hoops to get that designation, right? Now, the difference between NSQIP before and after is now with ACS verification, you have to demonstrate that you're using your NSQIP data for quality improvement. And you saw on this slide I just showed you, there's a lot of yellow, right? There's a lot of as expected. And so a lot of hospitals, when they get the reports, there's really not a lot to act on. So we knew we had to really expand that for hospitals if we were going to require them to use the data to get better. And so the expansion over the last 10 years or so is on this slide. And we're actually collecting some pretty cool data now in NSQIP, right? So not only is it just morbidity and mortality, but things like, CT scans for appendicitis, how many patients, what proportion of your spinal fusion patients go to the ICU? And then we have time to OR for emergent surgical conditions, right? How fast do you get that button battery out? How fast do you get that kid with suspected torsion to the ultrasound and then ultimately to the OR? And so the report cards now are really cool because they give you all sorts of cool stuff, right, to compare and see where you want to focus your QI efforts. Where I think we made the biggest jump, though, however, is in 2021 when we did adopt appropriate guidelines for surgical antimicrobial prophylaxis and measures for that. And of course, I'm biased, right, because this is what I do and love. But this was the first time that the ACS did anything in adults or kids to look at some measure, in this case it was a process measure, that was relevant to everything, right? It wasn't just a specialty, it wasn't just a condition, but really something that was relevant to the broad spectrum of pediatric surgical care, right? And also, something that had obvious public health implications in it. So we were pretty excited about that. And we also knew that we had great data and there was a signal. So when we persuaded the ACS that we needed to adopt this was also based on a lot of preliminary data. This is some data that came out of my institution. I was working with Tom Sandora, that many of you know is the PEDS ID guy in my neck of the woods. And we used PIS to demonstrate that more than half of all kids that are going to elective cases were getting unnecessary antibiotics. And then when you looked at what the outcomes were, not only were there less SSIs, but there was definitely a ding where we saw an increase in C. diff rate. So it wasn't a harmless thing to do. And so with this, we were pretty fired up that we can make a huge impact by bringing this into the program. And so this led to a 2-year pilot project, a proof of concept that we could collect prophylaxis data and feed this back to institutions. Now, at this time, there was 127 hospitals participating in NSQIP, and we were hoping that we would be able to persuade about 25 to 30, maybe 35 hospitals to jump on board. And 96 jumped on board, right? Which overwhelmed us a little bit, but it was pretty cool because what that suggested that people cared about this stuff. They wanted to collect the data, and they all knew, like we did, that we were just scratching the tip. There was going to be a lot of crazy practice variation to act on. The goals of this 2-year project was not only to persuade the ACS that this should be collected at all 126 hospitals as a standard, but also to better understand what was going on, right? So we're going to have data now where we understand how bad the misuse was. We can create report cards for hospitals to act on. And most importantly, and this is where HSR people like me were very fired up, is that we knew that we would be collecting a ton of data where we can develop evidence-based best practices for kids, right? If you look at the SAS guidelines, IDSA guidelines, how many of those are based on pediatric data, particularly for surgery? right? It's like donut. It's like zero. So we knew also this would be the first time that the ACS could actually develop evidence-based guidelines, because that's not historically what it was in the business of doing. So we were really fired up on this. And so now I'm going to fast forward now, right? So we had this 2-year pilot. It was successful. The ACS adopted it. And since 2001, all hospitals, now 157, are required to collect the prophylaxis data, and they get report cards. So I'm going to share with you what the report card is all about, and then some crazy cool practice variation data. So this gives you a sense of the types of cases that are collected. These are elective cases, right? So these are cases where it is truly prophylaxis and not treatment of infections, and that's really important. This gives you a sense of the type of prophylaxis measures that we collect. So we have overutilization measures, which include use in low-risk clean cases. Post-operative utilization, we break that down if you give any utilization versus more than 24 hours, right? Because there's a lot of controversy whether or not which one of these is truly inappropriate or not. Use of overly broad spectrum agents. We have a number of underutilization measures, and this is super important, balancing measures, right? Because we have to know if you do better and be a good steward, if you're not a good steward, how are your SSI rates? If you want to get surgeons to change without having that balancing measure, there's not a chance, right? So we wanted to make sure that this was really a balancing measures report card and not just an antimicrobial stewardship report card. This gives you a sense of some of the rules, right? Some of these are pretty basic. You don't give the antibiotics after incision. We have basic spectrum guideline compliance rules. If it's a clean case, it's gram positives. If it's a clean contaminated case, it's gram positives and gram negatives. If it's colorectal, then you add anaerobic coverage. This gives you a few examples of what we consider overutilization, where a hospital will be dinged, right? So double coverage, use of extended spectrum agents like Zosyn and vancomycin for routine cases. And I'll take you through now one of the most contemporary reports to give you a sense of the practice variation across all these hospitals. So this is our latest report. So 65,000 patients, 157 hospitals, 156 hospitals. And this is the distribution of cases. And again, keep in mind that these are elective cases. And you can see there's a distribution, a lot of cases across a lot of procedure groups across every single surgical specialty except for cardiac. And they're different color coded based on the different specialties. And now we'll get to a little bit of the crazy practice variation. So this is kind of a 30,000 foot view of what's happening out there across these hospitals. And these are the models of overutilization and underutilization. So overutilization is in yellow. And this is the overall rate across the whole universe of NSQIP hospitals. And you can see that 22% are so 22% of the entire cohort, there's overutilization. If you look at use of overly broad spectrum antibiotics, 7.3%, 51, so still this almost the same as the phys data I showed you from 2016, still more than 50% of kids who are undergoing clean cases without hardware, without implantations, not using joints, right, not involving the spine, are still getting antibiotics. 40% continue antibiotics postoperatively, and 9% of those at least more than 24 hours. And these are the distribution of statistical outliers. So across those 150 plus hospitals, you can see there are a number of hospitals who are really good. They're exemplar stewards, others not so good. And then if we compare that to look at our balancing measures of SSI, the numbers are a lot different, right? Overall ISI, incision SSI rates, 1.6%, 0.5% for deep space infections. And whoops. And if you look at the distribution of outliers, also very low, right? So what this tells you is that there's a huge disproportion, right? A huge disproportion in terms of the amount of antibiotics we use to the surgical site infection risk, right? So if we think about public health implications of where we need to focus, I think it's pretty clear here, right, that we need to target this crazy variation in antibiotic utilization. Now, Catherine He was one of our great fellows who worked with us a couple of years ago. She actually acted as our ACS antibiotic fellow as well. And she did some great early work looking at practice variation and trying to make sense out of it as it pertains to postoperative utilization. And we wanted to start there because we think that postoperative utilization is probably the most important area that we need to focus on if you're going to overutilize. And what she characterized is tremendous variation when you adjust for the different types of cases that these hospitals do. So if you look at any postoperative prophylaxis, the overall rate was 41%, and it ranged anywhere between the relative risk was anywhere between 0 to almost 3. So when you adjust for different case mix across hospitals, there was a threefold difference in giving antibiotics. And the same was found for postoperative prophylaxis as well, greater than 24 hours. And where it becomes really cool is if you look at the correlation, right? So do hospitals who give more postoperative antibiotics, do they have better outcomes? And you can see the correlations here were pretty much flat. So even those that gave prophylaxis more than 24 hours, when you adjust for case mix, there was no difference at all in their SSI rates. And this actually has become super powerful to share with your surgeons, because when they see normative behavior, and you're not just telling them don't do it, right? If you're showing them that there are surgeons, there are colleagues across the nation that are using less antibiotics and getting as good or better outcomes, that's a really powerful motivator for change. And this also looks at the same data when you break it down into different specialties. Everyone looks like kind of a random dartboard, right? You put a blindfold on, you drink 10 beers, you throw darts. It's actually hard to get more random than a lot of what you're seeing on the screen. So I'll also show you some data for specific types of cases. This looks at the difference between any SSI rate across hospitals versus median postoperative duration. This is for spinal fusion cases. You can see the overall rate of SSIs is 1.2%, 0 to over 60 hours. And this is kind of a standard postoperative course. This is the mean duration at hospitals. The same thing for pectus. You can see the same thing for urinary reflex procedures, and then for clean neurosurgical procedures. So every one of these graphs is adjusted for different CPTs and severity, but they all have the same thing, right? There's massive variation, and there's no impact at all on reducing SSI rates. And this data here is shows the additional correlation data. I mean, this is not just for postoperative utilization, but this is for the other dimensions of misutilization. So on the left side, this is use of overly broad spectrum prophylaxis. And on the right side, it's use in low risk clean cases where it's not indicated. These graphs are a little different than what I showed you before, because over here on this axis, you have adjusted rates of overuse. And then over here, you have adjusted SSI rates. And the caterpillar graph here is actually the adjusted rates of overutilization. And so for hospitals, when you think about, do you use overly broad spectrum agents per your cases, it ranges anywhere between 2% up to about 30%. And the triangles here are your risk adjusted SSI rates. And so it gives you a sense here there's absolutely zero correlation. And the same thing you can see over there for low risk cases. And then if you put it all together, right, if you say, well, what if you overutilize for any reason? Do you have better outcomes? And you can see here the correlation is still really flat. Hospitals over here, about 15% of the time they misutilize. Over here, there's some hospitals that misutilize in 60% of every case. They give it too long, they give overly broad spectrum, or they give it like for thyroid cases where you don't need it. And this is probably my favorite data slide of all time when we put this all together. And what this is it gives you a sense of the distribution of outliers. So is a hospital a statistical outlier being better or worse than other hospitals? And so every one of these columns is a hospital. And then every row is a different utilization measure, with the stars being overutilization. And if you're blue, that means you're exemplar, you're a good hospital. If you're red, that means you statistically use more antibiotics, you're more outlier than in a bad way than your partners. And then the outcome measures for SSIs are down here, and hospitals are ranked from left to right based on how exemplar they are being stewards. And you can see there's absolutely no correlation at all. And those hospitals over here who overutilize every chance they get, they don't have better results. And you see one little ding here for C. diff. C. diff's not really that common of a problem. But this is really compelling data that there is really not much of a difference. So with these data, we also were able to identify the hotspots. And so this gives you a sense of what are the drivers of different conditions. in terms of the burden of overutilization. So not surprisingly, things like CNS cases, ortho cases are the primary drivers for prolonged utilization. Things like CNS cases and GI cases are the ones that drive the most the burden of overly broad spectrum antibiotics. And if you look at the contribution of cases where you're giving antibiotics for clean cases that are probably not indicated, pyloromyotomy, testicular cases, and cholecystectomy as well. And then this gives you a sense of actually where the overutilization is for types of antibiotics. And so not surprisingly, when we look at the clean cases, tons of vanco, tons of double coverage. This is probably not a shock to anyone in this room, right? For a cholecystectomy, for some reason, surgeons love to use gram-negative coverage. Last time I checked, it wasn't connected to any stool-containing organ. Same with small bowel procedures, a lot of Suboxone use, even though that these are elective, non-obstructive cases, right? So this is crazy variation, right? It's much worse than even I could find a picture, but this is the best I can do. So then when we come back and what are we doing about this? All this data that we have and all this insight hasn't made a difference. And that's where the verification part comes in that I talked about before. And when we learned about all this in the ACS and we had all this insight, we knew we had to change the verification program to address this directly. And so in 2021, the verification program changed where it now requires these things at verified hospitals. So when you guys get, you have your visit in 2 months, you have to put a presentation together talking about your antimicrobial stewardship program, how it integrates with surgery. So Lauren knows all this. She's like, oh my God, I got to put this all together, right? And demonstrate how are you using that report card. So it's a big deal because that's the first time the ACS ever connected standards with data. First time ever in 40 years, which is so cool, right? So then how do hospitals deal with this and what tools do we give them? So remember, I'll take you back to this screen here where we're talking about having really good data, right? To make guidelines, to have really good comparative data to prioritize your efforts. So I wanted to take you through some of this data and kind of give you a little bit of a story at our own institution. So this was our maiden report card back in 2021, right? And back then we were a high outlier for more than 24 hours of prophylaxis, right? Which is the worst thing you can be an outlier on, right? And like, oh my God, we are terrible. And it's like, we're Harvard, we can't be terrible, right? I mean, we're the Stanford of the East, we got to do better than that, right? And so we put together our stewardship program, which is a requirement of the ACS, right? Has to have a stewardship program for surgery. This is the picture I hate again, by the way, guys. And I'm the least important person on here. The critical people are Crystal Stroh, who's our ACS program manager at my hospital, and Sarah and Mari Nakamura. Many of you probably know Mari. Mari is awesome. And we work very well together. And what we did is we wanted to tackle this through PIPS. How many people know what PIPS is? PIPS, okay, a few people. So PIPS is our surgical performance improvement and patient safety, right? And so when you're a verified center, you're required to have these standard meetings, which are multidisciplinary. They break down the silos. And for this specifically, there has to be demonstrable integration between the ASP and the surgeons, right? And so we dedicated, so our PIPS process, this was our major project this year. And what we did is, I'm not going to go through each of these in detail because it's another talk, but we spent a lot of time learning what was the problems, right? It had to do with trainees, it had to do with the problem with decision support, and it had to do with a lot of misconceptions among surgeons, right? With the key one being, oh, all my partners do this. So unless you can show me that, it doesn't make a difference. I'm like, boy, can we show you how it makes a difference. And so over the next 6 months or so, it was a major campaign in terms of re-education, particularly with the residents who come in because they wrote a lot of the orders. And then we totally revamped our order sets. So simple. Kepsol, Q8 ×2 instead of ×3, right? You don't have 24 hours, you reduce by a third, and it's so easy. And we had the data to show surgeons that it wouldn't impact their SSRE. So guess who our early adopters were? The spine surgeons. How does that happen, right? So the spine surgeons and our orthopods got on board, and this is what happened over the following year. This is our rates of post-op use more than 24 hours. The spine, 41% is where we started, and we ended at 11%. And the other orthopeds, they followed along, right? They decreased everything. And the key thing when we presented these at our PIPS meetings, is this. This is all the surgeons cared about. SSI rates were flat. So as we drop down and decrease postoperative use, SSI rates are flat. And the other cool thing about this is there was an effect where other services started to adopt it. So this is overall all services over the 12 months where we dropped it almost by 2/3, right? So it was a really powerful because this SSI rate didn't change. You combine this, let them know that we will track these things and your partners over there across the nation are doing it better. They're better stewards. And guess what? Their SSI rates are low. That was a really powerful motivator. And so this is what our report card looks like now. So we're now exemplar with any post-op use and post-op duration more than 24 hours. And then also, just as importantly, our SSI rates are flat. Our rate ratios, like 1, and they didn't change. So we became better stewards, but we don't have more infections. And the other thing I wanted to point out here too is that we started kicking butt across the whole report card, right? So low is good. If you're low, that means you're an exemplar outlier and a steward. And a lot of this was driven by a lot of little projects that were carried out by our ASP program within the different departments. This was one that was carried out by one of my fellows, Mark Cashdan, where we did the same thing within our little microcosm of general surgery. I showed my partners that everyone else was not given antibiotics to testicular cases and thyroids and stuff like that. And they had just as good results. Everyone got on board. We reduced it tremendously. And we reduced our antibiotic utilization. And so this was written up and published in the toolkit so other hospitals can do it as well. So there's a lot of great work that's being done. For those of you who may not be familiar with the ACS website, right? So not only do we have all this information regarding how you're doing in terms of how you compare to other hospitals, there is a ton of resources about how to take your data, to dig down, outreach, and how to act on it. In fact, that whole project I just showed you about reducing postoperative rates in my hospital is a 1-hour presentation that's on there that you can look at, download the slides, and please reach out to me as well if there's any questions. A ton of resources for those of you who are interested in this work. So in kind of starting to wrap up here, thinking about, well, what about the data and the collaborative piece and all that good stuff? So the collaborative piece is also an area where a lot of people are working on. The Pediatric Surgery Quality Collaborative is a collaborative of about 30 participating hospitals that I had the opportunity to lead this project in the last year. And what we're trying to do here is learn from other hospitals. We're trying to really gather resources and insight. If you're a good steward, what can we learn from you and what can we share and what can we put it on the NSQIP website? This gives you an example of how this collaborative is rolling out. So we started with getting report cards from all the collaborative hospitals through DUA. And not surprisingly, the distribution of the 30 hospitals, it's just like the distribution across all NSQIP hospitals. Some good, some bad, and a lot of stuff to share. This is the first kind of drill down of the report cards across the 30 hospitals. They're ranked from top to bottom based on high performance, right? So if you're really good, you're in the green. If you're not so good, you're down in the red. And when you do well in one, you tend to do well on the other. But the idea here is really to make like a gene shift of where we want to focus those qualitative interviews and where do we want to get those resources. And this gives you a sense of some of the things we're going to be digging down with the qualitative interviews. You know, this is an audience that really appreciates this kind of stuff, right? Culture, infrastructure, you know, what are the process elements that really make one hospital successful and another one not so much. So the idea here is really to get a qualitative piece, what we can learn, and try to share this throughout the NSQIP community. So then now kind of turning our attention to the data elements, and that one of the things that has come out of this is a lot of insight about what are the drivers of misutilization. And so Catherine also did a study where she looked at within the general surgery area about what was the primary drivers of overutilization. And the first thing we focused on working with the ACS is, well, if we're going to prioritize, what are we going to tackle first based on burden? And so we decided to start easy, right? Asking the question, do you need antibiotics with coles, pyloromyotomies, and testicular cases? And so I'm going to give you kind of a really quick 30,000 foot view of some of these results because they are the best data that we've ever been able to get. They're multi-center, they're very rigorous, and they're all done very well with the ACS in terms of their analytic team. If you look at pyloromyotomy, it's a coin flip across the United States about who gets antibiotics and who doesn't. So this was a study that we propensity matched about 3 years of data, and you can see there was absolutely no difference in SSI rates. The belly button is not dirty, it's fine. You prep it, it's fine. Right? Laparoscopic orchidopexy, the same thing, no difference if you give antibiotics or not. Now, this is really important too, because you can extend this, right? If you don't have a difference in SSI rates, if you make an incision in the groin and you make an incision in the belly, then you're certainly not going to have SSIs if you make an incision in the groin only, or if you do an inguinal hernia repair, right? So you can extend this to basically every kind of groin procedure there is, and that is probably hundreds of thousands of patients. Now, sometimes though, you find stuff you aren't really prepared for or you're surprised about. So these are the guidelines, and these also mimic the IDSA guidelines for whether or not you need antibiotics for elective lap choles, right? Not when there's common duct stones, not when there's acute cholecystitis, but just elective cases. In adults, they say do not give antibiotics. And so 90% of pediatric surgeons give antibiotics for their elective cases. And this, to me, was the most juicy study, right? If we were going to tell 90% of pediatric surgeons that they were doing the wrong thing. We couldn't wait for this, right, this study. Well, what we found is a 90% reduction in SSI rates if you give antibiotics, right? How the heck does that happen? 4% down to 0.9. And this is really, 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 really good data. So we propensity matched this, we propensity weighted it, we did all sorts of things because JAMA Pediatrics also, like us, kind of didn't believe the results, but they were solid, right? We don't know why, but if you go back and you look at the adult data, there are several contemporary meta-analysis that suggest that there is benefit. So the jury is out, but the best available data in kids is, guess what? Those 90% of pediatric surgeons were correct. And we were the schmucks that told them they were doing the thing, right? However, we also found some opportunity. 30% of kids were getting extended spectrum antibiotics like cefoxitin, and there was no difference. So there was, in fact, an embedded opportunity to do it better. Now, who knows this guy? That's my buddy, Jason Newland, right? So many of you know about the operatic trial. This was the first funded study from the AHRQ that actually used the NSQIP data, the prophylaxis data, within an implementation trial. This is the cast of his co-PIs here supporting the rock star. And many of you know this was a study that we actually just finished where we're looking at outcomes, again, using the NSQIP prophylaxis data and the NSQIP outcomes data. And this was a cluster randomized step wedge trial where we compared order set changes versus order set changes in some facilitation and implementation science. I can't tell you the results of the study because they're being written up right now, but they are friggin' awesome. And they were just used to us to get another R18 grant to expand those outside the 9 centers because there really is some incredible opportunity here. So stay tuned for that. And then kind of starting to wrap up now in terms of data, there are some efforts out there to use that NSQIP data outside of the ACS. The EPSN is the Eastern Pediatric Surgery Network. So this was developed in 2019. There's 21 hospitals, and it was developed really to pool data so you can do studies you couldn't possibly do with a single institution. And so Association of Postoperative Antibiotics and GI Cases was one of the 2 proposals that were sponsored for this year, which is awesome because what we're going to do is pull the data in a de-identified fashion and trying to answer these same questions, drilling down to those important and very, antibiotic intensive GI cases like colorectal cases. If you're a high intensity hospital, do you have better outcomes at the patient level? If you give antibiotics after the incision is closed, do you have better outcomes? Right? These are super hot button topics in pediatric surgery right now. And then finally, in wrapping up with the data, I also wanted to kind of change directions here a little bit. And so far, we're talking all about prophylaxis data, right? So there are ways that others are using the data in NSQIP for antimicrobial stewardship. And I'll just point to you really quickly in terms of an effort that we did. It was one of the first ever EPSN sponsored studies, and this was optimizing antibiotic stewardship in pediatric appendicitis. And again, this is what came out of our institution in terms of the PI and organizing center. And basically what we did is we just used the NSQIP outcomes, the SSI outcomes, which are gold standard, and had different institutions collect all the supplemental data. And what we found is a lot of really compelling data to really change how we thought about appendicitis care. We found out that redosing before the incision, if you already gave it in the ED, did not make any difference. If you're a ceftriaxone and Flagyl center, you can do it as much as 24 hours before, and it didn't make a difference. If you look at giving antibiotics for gangrenous appendicitis, no difference across centers in terms of their intensity of doing this. And at the patient level, absolutely no change at all, right? About 70% of patients get antibiotics after gangrenous appendicitis. And then finally, this was the best one, Zosyn, evil Zosyn, right? So this was the first time ever we had multi-center culture data to go with drainage procedures. And compared to patients who got ceftriaxone and Flagyl, there was no difference at all in percutaneous drainage rates and also overall cultures. And this is the best one. If you look at the distribution of cultures, 104 from 17 centers, if you use Zosyn, you were no less likely to grow out Pseudomonas, but you were more likely to grow out E. coli. And you were trending toward higher culture pulse positivity. That's pretty crazy stuff, right? But this is the first time we've ever had multi-center data. And so in wrapping up now, just a few kind of tidbits of what's coming down the pike. We just released the first report for appropriate antibiotic utilization for penicillin allergic patients. So people are now getting that report as well. And guess what? It's ugly. Missing documentation in 28% of all cases. And when there was documentation, you did the wrong thing over a third of the time. Usually you're given Clinda or Vanco if you have a mild allergy. I don't need to go into that detail with that with this group. Measures of appropriate redosing is coming in 2025. And then we're starting to really think about kind of capturing and quantifying antibiotic utilization with infections. And so finally, to wrap up just a few take-home points, the West is wild, but there are opportunities, lots of opportunities across many hospitals. You just have to find them. And again, using your NSQIP data is the way to do that. And I just want to emphasize too, the low-hanging fruit where we have now the best available evidence. And this is something to take back to your surgeons, because I will almost guarantee you that you have one or two opportunities here. So with that, I'll wrap up. And again, thanks, Lauren and the PEDS department for the opportunity to come back to the farm. And I really look forward to hanging out with you guys today and learning about all your great work. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.